So I think we can just cap up the session and finish up with some of the questions. Let me see. I think we left off in... So there was this one question where the question was, intubation seems to contribute to morbidity and mortality. Can the Austria vent be used with just a face mask? And so I think whether Bob can just comment on that, whether it can be used with a face mask.
Yes, it was really designed for face mask use. I don't know if it can be used for intubation, but there has to be a tight seal
Okay.
of the gas, of the air. Otherwise, there will be leakage, and it will not generate the PIP and the PEP.
Yeah. Okay. And then I think the other part to that whole concept of intubation seems to contribute to morbidity and mortality. I think Edsel made that comment where, early intubation is discouraged for certain patients, but when people do need intubation, mortality isn't necessarily because of the intubation, but it's a marker of the gravity of the patient's condition. And then from Al again, he asks for Bob, the DOST, I don't know how you say that, Picard was planning to procure a ventilator simulation equipment. Picard, okay. Was planning to procure a ventilator stimulation equipment from California, US in the discussions in April. Did it happen? And can Dr. Balgos and Dr. Bundok, can they use that?
Actually, this our team, which is DOST funded, that ordered for this, that's what I call the ASL 5000 simulator. It's a simulator that is being used by major ventilator manufacturers worldwide. We wanted to order, and we did have initial funds from the DOST for 3 units, but because of the severe need for it, our order was backtracked, and the first unit that we will have will be delivered only in the early part of September. That is what I was talking about in my presentation. This simulator is able to simulate a patient on a ventilator with pneumonia, with congested heart failure and alveolar flooding. So it can simulate many clinical scenarios without hooking the ventilator to an actual patient yet. And this is going to be really useful for the ventilator developers, because this will make us more confident about our ventilator capabilities even before doing the field testing.
Okay. So at this point, does anybody have any other questions? I mean, if you do, you can just literally turn off, unmute yourself and ask for our last 3 speakers, for any of the earlier speakers. It's your last chance.
Jemima, before we entertain some more questions, I just want to ask Dr. Balgos and Charles, what are your thoughts about intubation and mortality? I know we were pushing for early intubation before. Now we're sort of holding off. What are your thoughts?
Yeah, I mean, I think in the beginning people were worried about transmission, right? And so they wanted to be a more controlled intubation, and so they want to do it earlier to prevent the spread. I think that resulted in a lot of patients who have less severe disease being intubated, and I think it sounded like it was a bad idea. I think, there's a lot of use of high flow nasal cannula now, and there's a lot of use of non-ventilated patients doing proning prior to being intubated. So I think there's different modalities that we could prevent patients from getting intubated. And we've learned how to get more PPEs. And so I think that has helped to have it a little bit more wait until the patient needed it. Some of our experience in the ICU, encouraging patients to do self-proning while on high flow on the awake patient. Sometimes it's not perfect because they're awake and it's not the most comfortable, and you don't do it perfectly. And And so you kind of fool yourself sometimes because their numbers are good, but they're not really. And then people go up on the oxygen level, and but people underestimate how bad their lungs are, right? Because if they were intubated on a mechanical ventilator, you would know the numbers are really horrible with the PEEPs and the FiO2. So I think right now, I think people have a better idea of it, and there's a lot of talks about the compliance and how there's different physiologies of the lung. We also know that there's a lot of vascular disease, right? Thrombotic disease, and some of these patients having pretty good compliance despite really bad oxygen. And so I think the ventilator has really taught us a lot about the physiology. So without that, and people are on high flow, you don't get that physiology that much, right? You kind of underestimate the physiology.
So so Dr. Balgos is also a pulmonary physiologist. That's actually when I first met him. So since Charles started talking about physiology, Dr. Balgos, what do you think?
Actually, I'm not gonna talk about my experience, and I'll be talking about data from Gattinoni and co-workers based on the autopsy studies, I think from Italy and from the initial data from New York, which shows that they actually think that there are two phenotypes. There's the L and the H phenotype, where the L are the people who have less need for positive pressure and they just need high oxygenation. And these are the people who do not need intubation and who will just probably be benefited by just proning, even if they're not intubated. Uh, High flow nasal cannula, maybe even CPAP, and maybe this is where some of the insufflators will come in, non-invasive ventilation. But there's a subset that they classify as the H type, who would need high pressures. So basically, the approach of intensivists and pulmonologists now is they have to look at the baseline physiology and clinical status of patients. So if there's, for example, a lot of interstitial infiltrates on X-ray and CT scan, and there is most likely going to be a lot of increase in resistance. These are people who must not be given high volumes and high peaks because they will develop barotrauma. So these are the people who will probably be given only 6 pills per kilogram body weight tidal volumes and peak that is no higher than 10 centimeters water because giving more will probably contribute to barotrauma, and this is where that generalized statement that ventilators are dangerous for these people. But actually, it's far from the truth. There are really some patients who would need intubation and who need the standard ARDS protocols. But there are people, and I think we're now seeing more and more of these people who just need high oxygen and just some assistance for the breathing during the time that they are not yet developing the cytokine storm, and the lungs are still able to oxygenate.
Okay.
Back
Yeah, I
to you,
think that's
Maima.
I think that's interesting how in one of the questions where there's a surge now, so what now? But I think you can see how things have evolved over the last 5 months that we're in better shape to actually take care of the unfortunately likely second surge. So there we go. Now, I think that might be it. There's just one question about potentially fast tracking the approval and field testing process. I don't know if that's possible in the Philippines, but that has been raised. I don't know if anyone can take that question. So it's basically asking, with the current pandemic, can the Philippine regulating and approving agencies consider fast tracking the approval and field testing process? I don't think we have anybody from the approving agencies on this call.
I'm not familiar with all of the participants. Maybe some of them have worked with the FDA and have an idea whether this is possible. Just send me a message. I'll unmute you
Yeah.
if anyone knows anything about the FDA in the
Or
Philippines.
raise the hand. Oh, Alter Africa raised the hand.
Yeah. Um,
Perfect.
if I may, for our Ginhawa project, we have actually already requested FDA approval for our earlier prototype, and that was actually around 3 years ago. And we were given uh, interim approval pending the human field studies. However, we were the ones who stopped the process because we felt that we had to give more features and safety features to our prototype. So we stopped. We asked for a change in our budget and project study, and therefore we are now working on this new prototype. So right now, the only advantage probably that this pandemic has given to us is that the DOST has assured us that although our initial target for our field study is 60 patients, because of the use of the ASL 5000 simulator, we are actually being instructed that after the first 10 patients, we are going to have a safety committee review the performance of the ventilator even in the first 10 patients and see if we can actually do early termination and already proceed to manufacture and mass production. And so I think the FDA, although I have not talked directly to them, we were talking to the DOST, will most likely give an early approval if we put together the safety committee, which is going to be composed of the FDA, the DOST, independent biomedical engineers, and clinicians to evaluate the performance of the ventilator on the first 10 patients we have.
So Al,
Thanks, Bones. Yeah, I'm okay, Vince.
Yeah, go ahead.
Yeah, thanks. Thanks, Bones, for the update. Definitely, I'm hoping that we can get your Ginhawa already in the clinic if the need arises. I'm so happy to see 3 active models right now between Vent 2 and the TIP model with Dr. Bondo. And the fourth one, that's of course not discussed on the table, which is a manufacturing scale ventilator of Ayala IMI that was part of the UK Ventilator Challenge, was made available to the Philippines actually as early as June. They told me if we can find a clinical team to evaluate it. So we did ask DOH, so they can go ahead with their validation study. That way it can be in the clinic if the need arises as well. So with all these 4 options, I think I told you guys when we met on this one as early as in March, that this is a rat race. I mean, it's a horse race. Whoever gets in there gets used. And that's actually what the FDA has kind of intimated to us, that being that it's an emergency use authorization, similar to what the US is doing in diagnostic kits, in doing it in cure, as you've heard it from Dr. Malinis. And definitely the same applies, hopefully, on ventilators. Luckily, we're not needing it. We're only at 28%, I think, in utilization right now, and our doctors are doing a good job preventing them from getting to the point where they need intubation and ventilators. So I think, but nevertheless, the next stage would be clearly the regulatory and certification and validation and clinical study. And again, as I told you early on, I had a medical device company in the US for 20 years. That's what I do for a living for about 20. So I'm wanting to help you guys, not only from the initial design control documentation to the certification, and then hopefully get to the clinical approval for testing. And so good luck with all 3 presenters. And again, looking forward to assisting you guys in the near future. But thank you for actually joining us in PAASE. I'm past PAASE president in 2017, and I'm so happy that Vince came up with this roster. Good job, Vince. Thank you.
Thank you.
Okay, I think just one last question, and it's been a long night, in mourning for the people in the Philippines. So, any data on acrylic box or barriers? I guess they mean for intubation.
Yeah, for
Vince, maybe you
intubation.
can just take this.
Well, I don't know any data. so
We
so
don't use
Efren's
it
my
here.
classmate. No, so Efren is my classmate. I asked him to ask a question. Now it's fired back. Now I need to answer his question. I think there's I think in New England Journal of Medicine they had like some video uh intubating with an acrylic box, and it's a physical barrier, but I don't think I've seen any data to actually quantify how much comes out of that barrier. I don't know whether Dr. Balgos or Maricar or Charles know have more information about acrylic boxes during intubation.
Yeah, sorry, I don't.
We don't use it here.
Yep.
I mean, they use it in
Dr.
the
Balgos?
ER,
Yeah.
but I don't know if there's concrete data of
Yeah.
showing it reduces the risk of transmission. I don't know if Charles. I'm putting Charles on the spot.
I've seen it used in our hospital, but I don't think they've done a study yet. I mean, I think it's not consistent in terms of the use. I mean, I think last time I was in the ICU, I saw them sitting outside the ICU. I guess I think the concern of I mean, people are having full PPEs when they go in. The anesthesiologists who do a lot of the ICU intubations, they have even the full head cappers, and for it, and so they limit the number of people in the room. So potentially, but I think I haven't seen the data, unfortunately.
Dr. Balgos was raising his hand earlier.
Yeah, I agree. I don't think there are studies on whether these aerosol boxes has prevented spread of infection, but I would dare to say that because of the aerosol generation that is being generated during intubation as well as other procedures, I think the healthcare workers would be better off using what we call PAPRs, purified, powered PAPR, purified airway air pressure respirators, where air is pumped in, which is actually through HEPA filters, and it creates a positive pressure in the face or in the shield, so that the aerosol is not the chance that the aerosol virus carrying aerosol carrying the virus would be less likely going in. So I work and practice in a small private hospital, but we actually use the APRs. Although we actually have the aerosol boxes, but we still encourage or actually almost force our healthcare workers to use the APRs.
Okay,
Okay.
so it looks like we don't have any more questions. So one last chance to put in any more questions. 3, 2, 1, done. Okay, so that's it. So thank you very much for presenters for sharing their wisdom, and to all our participants. It's been a long night, but very fruitful. Well, day in the Philippines. Very
Thank you, Vince.
fruitful, but very productive. So again, thank you everyone, and good night, and enjoy the rest of your day. Thanks.
Thank you very much. Thank you, PAASE. Good night.
Good night.
Thank you too. Thank you.
Full screen. Is it full screen? Yeah. This is just